Good evening, everybody. Can you hear me?
Yeah,
Can you see the screen, sir?
yeah.
Namrata? Okay. Thank you very much for the kind introduction, Namrata. And today I'll be speaking to you about the RTO 800. A year ago, we have procured it and my experience with it and how I feel at the end of 1 year, how we have progressed with the new technology. Uh, as we go back to the history, you can see that in 2010, when Weinstock et al. Described their experience with the three heads-up display while doing phacoemulsification, it was very premature to understand that this technology would evolve so well and would be so useful not only for anterior segment surgery but also for the posterior segment surgeries. So this equipment we acquired sometime in the month of January at Ojas Eye Hospital, Bandra, and since then we have been performing anterior as well as posterior segment surgeries. It is one of the first only digital microscope in the market along with the Infinity, but the RTO 800 has proved to be more test of time because it is has the least amount of lag time and is truly a digital microscope. So why do we talk about this is because there are some features which are unique to this microscope, and some of them are as follows. The auto adjust feature which is there in this microscope, it anticipates the surgeon's workflow and provides an automatically adjusting settings without the need for any additional interaction when you move from the anterior to the posterior segment. Also, there is optimum visualization for both the anterior as well as posterior segment. So this makes it very less of cumbersome when you are doing your surgeries, both the anterior and with good depth of focus for all type of procedures. Also, the digital optics technology has a higher resolution and provides better light transmission than traditional optical microscope. And it uses lower illumination levels, which translates to greater patient comfort and it avoids phototoxicity. It also provides high resolution and remarkable depth of field even with the low light intensity. The hybrid mode also allows to view the surgical field using 3D imaging on the screen as well as through the oculars. So whenever you want to shift, it is an easy shift from the oculars to the digital screen, especially in the early phase of learning and also in some complicated cases where you feel that you need to use the oculars more than the digital screen. So this hybrid mode gives the equal amount of resolution for both the when you are looking at the digital screen as well as when you are seeing through the ocular. So there is 25% higher resolution of the optics and 25% better light transmission. It uses two 3-chip 4K cameras that provide a fantastic stereoscopic vision and it eliminates any signal delay. Thereby we get clear images without any lag. So this lag time is less than 50 microseconds and this is very much acceptable even when you are looking through the ocular of a normal microscope. And it provides extremely high power. Therefore, a high intensity light isn't needed compared to other optical microscopes. The viewability and image quality is excellent because we have a 55-inch 4K resolution monitor and there is outstanding depth of field and high resolution image with natural color. And the smallest part of the eye is viewed and magnified stereoscopically. The monitor should be, however, positioned approximately 1.2 meters from the surgeon to help him to see in a more comfortable position and rest. Even the team of should be able to access a very clear view. Another important aspect is that it is ergonomically very comfortable with the heads up, and a person can sit in a comfortable position during surgery, and you could even change the position freely during surgery. There is less of muscle discomfort, and it eliminates strain on the neck and the eyes. One is more easy through a procedure which could reduce the likelihood of surgical errors. Also, it is very well integrated to the Zeiss cataract suite. So it has a cloud connectivity with easy data transfer from the IOL master. So there is easy access to the patient data remotely and at any stage in the pre or intra or the post-operative period. Also, intraoperatively, we have access to the patient identification, the IOL specification, and the phaco parameters, and it can be overlaid onto a real-time image without blocking the surgical view, thereby enhancing the efficiency and safety during surgery. Also, it is paperless and markerless procedure. It can be integrated very well with the Callisto so that it provides a fast and error-free lens alignment for toric implants as well as for phakic toric implants. So the Callisto eye, it makes it a markerless alignment system which helps to guide you to the site of incision for capsular axis diameter and well-centered capsular axis, as well as astigmatism target axis both for toric as well as for phakic IOLs. The overlay for the toric IOL alignment is projected in the three heads up display, and the reference overlay consists of three parallel lines with the central line corresponding to the target axis. So thereby it optimizes our refractive results very well. Also, there are no pen marks on the eye, and it compensates for the cyclotorsion as the limbal vessels are taken as the reference point. So here I'll be sharing with you a video of the procedure.
So the video is not playing.
Yeah, one second.
I think the hyperlink files have a little bit of problem. They will not play from there. You'll have to play it from the source.
Okay. No. Should I go back or?
Yeah, maybe you can minimize this and then go to the video directly, open it.
I said just stop here for a minute.
Yeah, one sec.
Yeah.
Yeah.
Can you see it? No?
Yes, perfect.
Can you push it to the
Can we
start?
start it from the beginning, please? Yes.
Yeah. So this is the, what I'm showing you is the phakic implant. And here we have done the marking for the axis of the implant as well as the 180 degrees. So this is the phakic implant, and here you can see that here we have put the lens in the posterior chamber. And now we are just aligning the axis. And the axis is very well aligned here, like you have it right on the dot where we can see the marking on the lens and the markings on the cornea, which are well in position. So sometimes you may have to do a little bit of manipulation in the eye and rotate the lens if it's not exactly in the middle. Okay. I have another video also. So I'll just see if this opens, otherwise. Can you see it?
You have to share it. It is not shared.
Yeah, one. So should I go back or?
Just click on the screen share button first. The green button.
I don't have that screen share coming on my. I think it's directly playing. 1 second. Can you see my screen or?
No.
The same way you had shared before.
Yeah, but. I'm sorry, I don't know. 1 second. Yeah. Yeah, now should I?
On the Zoom window, you will have to.
Yeah. Now has it come?
Let's double click on it. It's not started.
No, I don't know why it's playing on my screen here. Should I? Can you see the screen now?
No, actually, it's just showing the two icon. Yeah, now it's visible. Yeah.
Has it come?
Yeah, it has come.
Okay. So this is a trifocal implant, which is a toric implant. And here the data from the IL master has been transferred to the machine here, the equipment in the RTO. And here we are doing the, we have already done the data transfer, and now we are doing the surgery with the capsulorhexis and then the PECO. And here you can see that ergonomically it's very comfortable looking at the screen here and performing the surgery. And just that you have to be at a particular distance, about 1.2 meters away, so that you can minimize the factor of accommodation and you can clearly view with the 3D glasses. And here you have two screens, one which is a 3D screen and one which is a 2D screen. And also this, it is good for the staff also because they are also viewing the procedure well, and it makes it a good teaching tool for students who are around us while performing the procedure. Here, another important thing is your hand-eye coordination when you are looking straight at the screen. And while you are entering the wound with the instruments, it is very important that you are in the right plane. It takes initially uh, a few surgeries to get the hang of holding the instruments into the eye looking at the screen. But then once the hand-eye coordination is comfortable, then you get used to the whole procedure very well. And here the important thing is that you see the even the posterior capsule very well. You see the cells on the posterior capsule well. Up to the mid vitreous, you even see the floaters in the vitreous very well. And here, once you have implanted the lens, then we activate the Callisto markings, and the toric alignment is then done by first rotating the lens to a particular, near to the particular axis, and then aligning it in the right position. So once you have brought it near to the three lines, then you just remove the viscoelastic from both the above the lens as well as from underneath the lens, and see how you can align the markings with the central line so as to be exactly at the right axis. Yeah. So now can you see my screen now?
Yeah, we can.
Okay. So the other added tool we have is the intraoperative OCT, which the next speaker will be speaking about, and that helps in just streamlining your surgical decision making. It gives a real-time insight into the surgical dynamics and tissue manipulation, and it also ensures correct tissue placement, especially for other types of surgeries besides the cataract surgery like the DMEC, DSEC, and also the INTACs. Also, it increases the safety and the optimizes the outcomes of the procedures. Here you can see how well the OCT demarcates the placement of the graft for DMEC tissue as well as for DSEC tissues. So the other advantage we have seen is in the COVID-19 era with the 3D heads-up display that it becomes a good interactive teaching tool, and it decreases the proximity between the surgeon and the patient while you are operating. But the main challenges we have seen is a couple of them. That is, you need a bigger OT space than with a regular OT space. So that is something which one needs to look at. And also the cost of getting this equipment, because the equipment does cost a sizable amount. So it's important to take these factors also into account. In our experience, we have done almost about 840 cataract surgeries with 5 PKs, 2 DSECs, and almost about 8 INTACs. It gives an optimal, anatomical, and visual outcome. with no significant increase in the surgical duration. So as you keep doing more and more, the duration of surgery gets more and it gets reduced considerably. And there is a short learning curve of initial few cases to get accustomed to the changing dynamics and the positioning. So in conclusion, RTO 800 has brought a digital awakening in the surgical arena. It helps in better care and surgical outcome for the patient, and it enhances the accuracy and precision of toric implants, both ICL as well as the multifocal lenses, optimizing the refractive results. Also, least not but the least that it provides increased ergonomic health for the surgeons, and I feel that this is the future. And we at OJS are proud to be a pioneer in acquiring this equipment. Thank you very much.
Thank you, Dr. Nitin.